Yeah, okay. Assalamu alaikum, everybody. Bismillah ar-Rahman ar-Rahim in the word. Jazakallah khair, Munawwar. Thank you as always for organizing all this. I know as a jobbing orthopedic surgeon, I don't know how you find the time to do all this, but anyway, Jazakallah khair. It benefits us all ultimately. So you gave me the remit about rotator cuff tears and treatment, and I thought it's the sort of thing you can get away with when you start getting a white beard and you get a bit more senior. So hopefully you'll see where I'm trying to come from. So impingement of rotator cuff disease, and I think it's a continuum. It's common in primary care, where in the UK, as you know, we've got a well-developed primary care practice. The diagnosis can be difficult. Often painful shoulders are labeled as frozen by those who are not really very experienced. For me, it's really a large egg. What's the shoulder? It's a large egg on an undersized egg cup. And the humeral head needs to maintain its central rotation throughout the arc of movement. It's the joint with the largest range of movement, but it's as well out of all the large joints. The head and glenoid are covered by cartilage, which has a very low coefficient of friction. And then if you add a deltoid on the outside, the resultant vector is straight up. Unless so there's our egg on a cup, but that's actually a well-contained cup. This is a flat cup. Unless you have a functioning rotator cuff, which forms this continuous arc from the front to the back, as we all know, subscapularis, supraspinatus, infraspinatus, and teres minor. This is a nice view. It shows us basically the line of action of the rotator cuff muscles. It's 45 degrees to the coronal. That's the scap. And majority of the humeral head and the covering rotator cuff is uncovered, apart from muscle and soft tissue. Impingement. Well, that's a concept. Well, it's thought to be gradual onset, usually over the 35s, but I would qualify that now. I think a lot of more younger people are getting impingement, mainly because of our obsession with handheld devices, iPads, the works. And I think we're heading for an epidemic in the youth as well. It's a crowded space, but impingement can happen for a number of reasons and lead to a number of different around a very small area, from AC joint arthritis to bursitis, tendinitis, and bicipital tendinitis. If you're lucky, you might sometimes see the subacromial spur. This is one at the AC joint, but it's a rather for what you can sometimes see, although it's not usually as clear as that, as we all know. So what would you say is impingement? Well, the uppermost part of the cuff, the supraspinatus tendon, the top of the shoulder called the acromion. Sorry, it's a bit simplistic, but it is trying to encompass everything we would probably understand with impingement. In some people, the space between the acromion and the top of the humerus is quite narrow. And then the cuff tendons and the adductor bursa can become pinched, and the radiologist will tell you, we did an ultrasound, asked the patient to abduct the arm, the bursa was squeezed or was seen to be impinging. And we think, and this is all conjecture, we think this is what happens. With impingement, the tendons and bursa can become inflamed and swollen and cause the painful condition known as chronic impingement syndrome. That's what Nia said, or seemed to imply. And it seemed all hunky-dory. So if we open up, that should solve the problem. So here an example that most of us will have seen as operating shoulder surgeons. You're looking in from the back. You have this bony spur. You have the deltoid here. It could be whatever, approximately 3.5 to 5 millimeters, up to 5 millimeters. And we have an example of a large spur there. But surgery is about picking the winners. have the ability to repair very large tears. Surgeons are good at that. We can repair and bridge large gaps. But what are we actually bridging? I mean, if we bridge a senile chronic tear, are you doing that person any good? The data shows that we have very high re-tear rates. A few years back, a big study from Texas demonstrated that re-tear rates were between 40 to 70% in some cases. And this person had looked across all the trials. So our ability to repair and pat ourselves on the back at the end of a long or short case, whatever the case may be, is not mirrored by clinically successful outcomes in many patients. And we sit back and ask ourselves the questions. Muscle wasting, timing of the tear, and secondary tendon changes all contribute. We're not very good at looking or addressing. This is fairly random. Surgeries normally wear a sling. You can wear it for a rotator cuff. You can wear the sling up to 6 weeks, although I traditionally say 5 weeks now, and physio and the like. But we all know that. But what is the natural history of a rotator cuff? There is very little comparative information. But there was this important study, Yamaguchi et al. In 2003, and I'd ask everybody to try to go and read this, because sometimes with the technology and all that it entails, we do get carried away and we think, gosh, I can do this, I do a double row, I do this, and you know. But what are we actually doing? And the purpose of that study, and this is somebody like Steve Copeland who actually reminded me of this, and he said, Tarek, go and read this paper, it's very important. And the purpose of this study was to compare the morphology and incidence of cuff disease in people with unilateral painful shoulders. And not surprisingly, so there were 588, almost 600 ultrasounds, and 212 patients had bilateral intact cuffs, 191, about a third, had unilateral tears, and almost a third had bilateral tears. Remember, this was a unilateral symptomatic shoulder. They looked at correlated things with the data for age, cuff thickness, tear size, and symptoms were tested for associations. Not surprisingly, disease increased with average age. There was no tear at about 48.7 years. Unilateral tears were at 58.7. But then when you got above 60, 67.8, you started to develop these bilateral tears. And a logistical regression showed a 50% likelihood of bilateral tears after the age of 66, and that was very significant. So there is a natural history that as surgeons we need to be aware of, and we are fighting all the time. So a patient with a full tear on the symptomatic side had almost a third of them had an incident of an asymptomatic tear on the other side. And that tells you that full tear patients were often ones who were older. In contrast, asymptomatic or partial tears only had a 0.5 or less than 5% incidence of a tear on the other side. I know it's a lot of statistics, but I would really ask you to go and read this paper. It's very useful reading. In patients with bilateral tears, the symptomatic side was larger, and hence we think that's why the pain was happening. 65% of the painful tears were on the dominant side. Again, a question that patients will often ask you, is it because I'm right-handed, or is it because I'm pain in my left when I'm right-handed? For intact cuffs, average thickness was 4.7, was not affected by age, gender, or symptoms. So there's something the radiologists and we can hang our hat on this. So the high incidence of bilateral tears suggests that something else is going on, that this is an intrinsic process. And that doesn't surprise us. We are students of tendon and ligaments and bone and cartilage. And these are very structures that remain mystical. We don't really still, well, I mean, a common question the patient will ask you, what can you do with it when you lose cartilage? Well, there's very little we can do. There's probably some fancy little bits of surgery and little plugging of cartilage gaps, but there's not a huge amount we can do. But this doubt with the symptoms of hand dominance does indicate that intrinsic factors may be important in the development of pain. This was a study I did, initiated actually, and then it was completed after I'd left, where we did some in vivo measurements in the rotator cuff using laser Doppler flowmetry, and it was published in the Journal of Bone and Joint Surgery in 2008. What we found was that the so-called watershed area, which sits a centimeter away from the insertion of the cuff, was a control group who were all dislocation instability patients. And when we did the same laser Doppler studies on these patients, we found that there was no drop-off in the blood flow a centimeter away from the insertion of the tendon. And in fact, this was something that was developing, and we correlated that with the impingement and cuff patients that we were seeing in the other group. And that was found to be statistically significant. Bit of pixelation, but there's a large spur tear, partial tear, and this is a full thickness tear on ultrasound. And that's a tear as well, a full thickness tear. Again, another one. And these are the different processes and suture techniques we use suture passes. In my own practice, use helicoil. This is a very large tear, massive tear, going beyond the glenoid. Convergent sutures, and then trying to bring it together after a lot of release. But does the whole surgical improve symptoms? I'm sorry if it's not a technical exercise I'm showing you today. I'm trying to go beyond that and think about what are we actually doing and what are we achieving, trying to get us to all re-examine our practices as well. So a surgical episode for the patient to their normal work. It focuses attention on the problem. Physiotherapy, lots of medication, there's a high re-tear rate. So which is the bit that's improving the patient? There's no doubt, if you're well motivated and if you're compliant, then these people will do well. And these are people who don't do very well. Old age, chronic tears. There's no way in how old the tear is that you're seeing in front of you. This is a developmental process. It happens over many years. And by the time they come to you and they're symptomatic, that tear may have been there for more than a decade. And often the MRI scan will show you that there's marked missing. So, but if you have bad indicators, it doesn't mean you give up on these patients. There's lots you can do. This is a second rotator cuff arthropathy type picture. And you can improve their pain by regaining their range of movement and stretching range of movement. This is a severe rotator cuff arthropathy picture where the acromion is now being denuded as well. But demonstrate inability to elevate standing when placed. So you start teaching them deltoid strengthening exercises, 30 either side of the 90 degrees. No weights to start with, 5 minutes, at least 3 times. And this is demonstrating, you can demonstrate this to the patient in the clinic, and using your cuff, your strengthen your deltoid, your anterior, your posterior, and your middle deltoid, using that. When they can do that easily, then they start loading it. When they can do that easily, then they start sitting up. And there's this pyramid of recovery we'll be aware of. We need to regain the flexibility, strength, proprioception, then endurance in the muscle, and then there'll be this motor relearning process and hopefully some return to activity. This is a patient who had this, and 6 weeks later, it was weak, but she had good pain relief, and she was starting to get some function. So it's not the end of the game. But this is a rotator cuff arthropathy picture we will have seen. I think, Manobra, you do quite a lot of these.
Yeah.
And this is one option. The balloon arthroplasty, I've steered clear of. That's going through a national trial at the moment. But reverse arthroplasty is an option, obviously, in these cases. Thank you very much. I'm sorry, it was a slightly different slant, rotator cuff disease.
Okay, so there's a few things that I have, and we'll open this for questions. The first thing is, I do not repair massive tears because size matters. There is evidence to support that if you are bigger than 5 centimeter tear and you do a fantastic repair, they don't work. Right, so I do something else. So for me, size is important. I don't do all those difficult conversion sutures and repairs them, and then find out about 6 months' time it's all gone pear-shaped. But there is now evidence that we don't need to repair the massive tears. So I'll leave it to the audience what they want to say about that. The second thing is basics. The cuff acts as a support, and when it tears, it becomes a suspension bridge. Sorry. So that means it is hanging on either end, but there's nothing at the top to hold it together. But with that, if the deltoid is functioning, your physiotherapy that you just mentioned, Tariq, and if you've got a good physio, which I have fortunately, then you don't need to do anything. You train the deltoid to use a suspension bridge to make it work. Okay, and that's why it works in certain people and doesn't certain people, depending on how much tear you have and how big is the suspension bridge and how the deltoid works. The third thing is the young tears. Okay, so the young tears is a different ballgame altogether. I don't think so it happens the same way as in the elderly, because I think it's all started with the overhead athletes. They have a slap tear. From the slap tear, the shoulder becomes unstable, and because it's unstable, you get internal impingement and you get a tear from inside, which is what we call the pastor lesion, and that progresses and becomes a subscap tear. So the concept has to be very clear. If you go and start repairing the tear and don't go to the primary cause of it, then you're in trouble. And finally,
there's no doubt with these slap tears, for instance, I will get about 15 to 20 patients a year, and it's all the same pattern now. Young patients who are active, doing overhead, as you said, activities, maybe weightlifting, rackets, and some index incident happens and they get pain. They've been investigated. Sometimes they'll come through having seen other people as well. They've had MRI arthrograms. And then I say to them, look, the final diagnostic thing is we're going to do, and to me, they'll feel and look at tears. When I go in, often they'll either have a high labral tear, a very high one, or a slap tear, which is not very big. But these patients at the same time tend to be quite flexible, quite slack generally, and what's happened is that slap tear or that high labral tear has just brought them over the edge, and they start becoming symptomatic. They have symptoms they didn't have. And almost like doing a spot weld, you just repair it. It's a spot simple operation, and once they've done the rehab, I've never had one of those patients come back and say I've still got symptoms out of the ones we repaired. You'll find a third who are a bit mad and you don't find anything. But then you send them away and say,
God doesn't love you.
Go and see a good physio.
Yeah, so this is important. I'm grateful and glad that you understood this, but for the first 5 years of my career, I was doing these pasta lesions, and I used to cut them and repair them and was very happy about it. The problem is not the internal impingement or the sixth scapular syndrome or what people call them these days. This is a lesion that has started in an athlete, in the young person, from something happening in the labrum. So guys, all of you guys who are doing arthroscopy, keep your eyes open. A cuff tear is not just a cuff tear in a young person. You have to know why he's got a cuff tear, because it's not common for them to have cuff tears. And one more thing I was going to say to you before we can change. Yeah, I read that paper from Yamaguchi, 2003, amazing paper. It's a must for all these guys who are doing, massive cuff tears, because it is important that we understand what is the natural, sequence of consequences rather than trying to fix them all. Okay, so good. I think somebody, Tariq, Naveed, you wanted to ask a question, is that right? Tariq, did you want to ask a question, Tariq?
Hi, yeah. Sorry, I asked what's the threshold for surgery? I've written in the chat.
What do you mean by threshold now?
What's the threshold for surgery?
Yeah, no, I don't understand. What size it is, symptoms are? Is that what your question is?
Yes, because they said surgery is very high yield. We shouldn't do surgery just for the sake of operating. There isn't, the outcomes aren't.
Okay, so I don't understand. I could explain it to you, but 5 centimeter or more bigger tears, you should try to do something else. But anything else, young person, fit person, and everything else, I think it's an easy thing to do. But Tariq will explain it to you. Yeah.
So Tariq, I would say, thinking of Tariq, say you have a 75-year-old grandmother coming to you, and she's got a painful shoulder, and she's got a large tear. And you look at her generally, she's not in the best physical condition. She's got pain. You may do an MRI scan, find there's muscle wasting, but there's a tear in front of you. Now it's a surgical challenge, okay?
Yeah.
And then I would give you another scenario. A 35-year-old, 40-year-old has had a fall, obviously very active, has come to you, you do a scan, got a tear.
Okay.
Now, in the 35 to 40, I think most of us would agree it's a fresh tear in somebody who's active, relatively fit and well. I don't think there'd be any debate on whether you would repair it or not. Correct?
Yeah.
So there is an MRI scan.
And I think expect that as well.
Yeah, the cochlear will tell you that this is a patient that will help when it repairs or it doesn't have. And the other thing is you must all be aware of the Hamada classification. This is a classification which shows you how far the distance of the humeral head is from the acromion, and it will tell you how thick your tear is. And if you've got scalloping of the acromion, which is just the borderline of repairing cuff, I started showing you a picture of the acromion scalloping. So, and if it's arthritic, then whatever repair you're going to do is not going to work because the joint has got no cartilage left. You will have a nice repair, but no function. So it's not just a simple, straightforward, this one I repair, this one I don't repair. It is working with the patient, with your expertise, with your, limitations and patient limitation and the general health. Okay, so Sufyan's asked a question too, isn't it?
Just trying to pick the winners.
Yes, exactly.
The ones who are going to do best in this. Remember, surgery itself, although we're now doing through minimally invasive approaches, it's still for the elderly patient. It's still a challenge process.
Okay, got it. Thank you so much.
Yeah, but saying that, if you're a 75-year-old who got a cuff tear and you're fit, I would do a reverse. I would not repair the cuff.
So can I ask you another on that question? Yeah. There's no doubt. Well, out of the Stoker reverse studies for cuff disease, there is this phenomenon of deltoid failure as well, isn't there?
Okay, so you have to have deltoid working to begin with. Okay, so that's the first prerequisite. The second requisite is patients should be fit enough to have a haircut. It's very important not to put reverses into everybody unless you're, so the younger they are, the more fitter they are, therefore they have. So I've been putting reverses in patients for cuff tear for nearly since 2005. I have not had a deltoid insufficiency. Also, that's a very big statement to make, but that is the most common cause of failure for these reverses. The reason is the tension. You need to get the appropriate tension. If you haven't got the appropriate tension, they all will fail, the deltoids will. So I tell you, the example is I put a standard body, okay? And with a standard body, the insert that should be fit for it is a small. And every time I put a small in, if I have a small body, it's got to be a medium. However, if I have a standard body and I'm looking at medium and large inserts, then I haven't got it right. Something's wrong, because that means I'm putting it too tight or I put it too lax. So the tension is very important for the deltoid to work long term. I just remembered something. You remember, every cuff tear does not end up in a cuff tear arthropathy, because cuff tear arthropathy means you have fusion, you have crystalloids, and that's called Milwaukee shoulder. So it's not cuff tear arthropathy every time you have a cuff torn. It's just when you have the certain thing. Okay, so Sufyan's asking a question for a long time, Sufyan.
Hello, everyone.
You're asking? Yeah, we can hear you.
Yeah, assalamu alaikum, everyone. Sir, it's always a pleasure to listen from and to learn from teachers like Mr. Tariq Khan and Mr. yourself. And Mr. Tariq, there are just a few things that I would like to ask regarding the attempt to repair. I mean, what is there any the classification that you usually follow, like the Buccaneer classification regarding the repair cuff which be brought back onto the porosity? And because now in Pakistan, when actually I offer someone to go and have a cuff repair, they actually look at me like paranoid, like I am paranoid and offering some alien sort of surgery to them. So the thing is that I need to be very precisely sure that whether I will be able to repair this cuff, because in this, in Pakistani population, the maximum age up to which a lady or a gentleman can undergo surgery is more around 60 to 65, not more than that because of our age expectancy around that. And the second question is that whether do you augment your rotator cuff repairs by the use of the like PRP in order for it to actually work better. I have actually tried it in one patient, and interestingly, the results were very good in it. Thank you very much.
So, Jazakallah khair. Assalamu alaikum, Sufyan. With the PRP, I know people have tried it. My concern when speaking to them, the problem they have is maintaining the PRP at the site of repair. And the ones that I've spoken to here in the UK and US, they've said they've not had any major changes. I know you said one case did very well. I mean, just as an aside, my thoughts on the PRP is that we should probably be addressing the PRP more at the muscle that is attached to the tendon we're repairing, because that, I think, where it will make some difference, if it's going to make any difference, because trying to keep the PRP at the repair site is difficult. I mean, if you manage to do it, that's really good, but how did you maintain the PRP at the repair site? How do you know it's going to stay there?
So it was just an injection, and it was just randomly given without the use of an ultrasound, and it was given, one injection was given after 6 weeks after the repair, and the other one was approximately at around 10 weeks. So it was just a random injection.
Oh.
Okay.
So when you injected, it wasn't at the time of surgery?
Not at the time of surgery. So I just injected it once after 6 weeks and another after around 10 weeks after the repair.
Into the subacromial space?
To the subacromial space, yes.
Okay. So I have some experience.
That's really interesting. That's a totally different concept then.
So I have got a very box-like approach to these. If you're above 65, I will have a long chat with you before I would offer you any kind of repairs. I will go with the Hamada classification, see if you have arthritis and not if you have I would go with the size of the tear. If the size is bigger than 5 centimeters, I can have a very good repair, or I can struggle with the repair, but the outcome is poor. I did try putting balloons in the very thin cuff repairs that I was doing. They were too painful, and the patient did not like them, so I only did 5 or 6 of those, but I don't do them anymore. Coming with the PRP, I do what is called tender ACP, which is a scaffold with collagen that I inject directly into the repair. I have got Arthrex backing me. I have one of those SOS software given to me, so I have got about 11 patients. It's too early to say, but I have got no experience in repairing and injecting them afterwards. I have injected people with small tears in the clinic, ultrasound guided, but again, it's not PRP, but it's tender ACP, which means there's collagen with the PRP, and I have about 11 or 12 patients, and they've done well. So I've not repaired them, just the injection has got them better. So that's my experience, but it lacks evidence, and it's not evidence-based. Yeah.
Sir, if you just allow me one more question.
Okay. Go on.
The thing is that eventually you say that if the tear is a prolonged tear, and you actually go and strengthen your deltoid, and the deltoid takes over the activity of the cuff. So the question is that eventually, because I've seen patients here in Pakistan that people actually have got no concept of going to surgery, and the cost of anchors is very high, so they avoid going into surgeries. So I have seen patients with massive rotator cuff tears, and developing a little bit of an arthropathy along with it, but the delta has actually taken over those effects, and they are doing really well. I mean, the pain is not. The pain is not 0. It's between the scale of 1 to 10. It's around 3 or 4 pain, but they're managing about it. So the only discussion is that whether it eventually deltoid has to take over the function of the cuff, and again, why to actually go for cuff repair?
So we live in the first world. My patient wants to go back to work tomorrow. He has got a mortgage to pay. He has got various other things. He has to make money. So for me to tell him that your shoulder is going to be all right in 2 years, which is what the evidence is. If you repair cuff and you don't repair cuff by 2 years, according to that paper from Yagamuchi, they will do well. Okay, that's because the deltoid starts helping. Like I mentioned, there is that drawbridge effect, or the tension bridge effect, where you have attachment on both sides. They will eventually be strong enough to pull the ball back into the socket, and then the deltoid will work. So they all in 2 years' time will work. It depends on if your patient is willing to wait for the 2 years. It's the same as frozen shoulders. At 2 years, they will thaw out according to that Codman, definition. So it is not because if you leave them, they don't work. It is because the patients want to go back to work and want to do things now, not wait. That's the difference. And I agree with you that if your physio is very good, understands what they're doing with it, you can give them function because the deltoid will kick in and will take your function. I have seen loads of patients, not just one, loads of patients that come in, they have massive cup tear, but they surprise you by doing function. Right? So your question is very genuine, okay? But it is the explanation is you will repair the patients that want to do something now, not wait for 2 years. That is why we repair them here, because my patient, like I said, has mortgages to pay, has got to go back to work, has sports to do, things like that. Is that right, Tariq?
Well, the other thing is though, Sufyan, the elephant in the room is the fact that there is a high re-tear rate with all these tears. And you're right. Why should we? I think it's a genuine question. Just because we can do it, the technique, but when we do informed consent, I do tell the patients, look, there's a significant re-tear rate with these repairs. The best answer I've had to a shoulder surgeon was, well, it does re-tear, but not necessarily to the same size it was before you did the repair. So what that tells me possibly is that the viable parts of the cuff have repaired, the non-viable parts are not repaired. And this is what was one of the reasons what drove me to do this laser flow study, is that we need to find some more way. Look, when the general surgeon repairs the bowel, right, he will look at the bowel macroscopically and think, without any doubt, he will cut out the dead tissue because he doesn't want a patient where after he's done the bowel repair, the patient perfs again, because that's life-threatening. But we don't have that situation. We have a situation where, okay, the arm won't move, but at least they won't die. So we're pretty, well, not reckless, but I think we're pretty gung-ho in trying to repair most things that we see in front of us, but we don't actually look at the qualitative issue of the tissue itself in front of us.
So my short answer to that is, when I was young and pretty and beautiful, I used to repair them all because I could. Now I've learned a lot of lessons. Biggest lessons I've learned is if the tear is bigger than 5 centimeters, it will not heal. It will heal, but it will re-tear again. So maybe what you do is you put it back into where it should be, and the deltoid burns and has muscle patterning and memory, and therefore the shoulder moves. However, be careful that the 5 centimeters or bigger tears, they don't do well long term. So just be sure what you want to do with it. But I have stopped doing a lot of repairs that I did in the past. And my saving grace was the reverse shoulder. And in the 65 plus, maybe 70 years old, I don't even go for repairs. I just do the reverse straight away. And I have a big series. I've got more than 500 reverses now since I've started doing them. I have maybe 2 or 3 failures. I've had no infection. I've been very lucky. I had some dislocations. I think Sufyan was here when I was starting to have dislocation. That's because I didn't understand the concept of center rotation, but I do now. But yeah, life changes. You don't have to repair everything, but you need to know which ones you're repairing. Pick your winners, like Tariq said at the beginning. Okay? If there are no questions, shall we move on to my small talk? I'm going to be a bit controversial today, as normal.
Yes, please.
I hope you guys can bear it with me. Okay? Just a gambler's view of the shoulder also. Okay? Should we start? Or do you have any more questions, guys?
Or can I just ask a quick one?
Yeah. Go on.
Thank you very much for ending on this. For like a massive old patient, massive cuff arthropathy, like 70 years old or something, and the plan would be fine, recruit the biceps and get on with it. But if but like a painful arthropathy, would you recommend a steroid injection or not? Or just
So I am very controversial on steroid injections. You have stirred up.
That's the question, yeah.
So steroid is only a diagnostic test. It is never used for treatment. If you think it will fix it, that's a bad thing. So a cuff tear arthropathy is a totally different thing. Not everybody ends up with a cuff tear. In a cuff tear arthropathy, that's a Milwaukee's shoulder. Any kind of surgery you're going to do for it is not going to work because you need to do something to take the disease out. And in a massive cuff tear in a 75-year-old, if it's more than 5 centimeters or bigger, the outcome is very poor. So I do other things, okay? But I'm sure Tariq will tell you because it's his topic and I'm jumping into his domain all the time.
you're talking about a cuff arthropathy, which is painful. I have used hyaluronic acid, I have to say, and in some patients, in over 2/3 of patients, it works quite well. Problem with steroid, it does give but I always say you have to combine that with deltoid strengthening. I get them to go, once the pain is reduced, then I get them to go and see a good physio to do a whole regime of the deltoid strengthening exercises. But if not, then you're talking about reverse.
Yeah, I mean, arthropathy, in my view, is a different ballgame altogether. It is not the end result of a cuff tear. That's what I think, anyway.
Sorry, what did you say, no?
Yeah, so I think the cuff tear arthropathy is a different ballgame. It is not an end result of cuff tear. It's a totally different pathology, different beast.
Okay.
Okay. So I'm going to talk about a very not a difficult, but a very exclusive. I don't know how to get it now. I'll be telling out people how to do it, but I can't do this now. Slideshow from beginning. Okay.
Yes.
So basically, what I want to talk to you about is my view on the proximal biceps tendon. Okay, and the long head. You know, there is no conclusive evidence, and there is no agreement among shoulder surgeons. Is it an appendix of the shoulder? Is it a humeral head depressor, or is it a source of pain? And most of us agree that it is a source of pain. However, nobody agrees to the fact is that it does anything else beyond that, although there are a lot of papers around which tell you what it could do. Okay, so we understand that if you do a lot of data on biomechanical studies, the question is not answered. We have three options or two options. The first is that it could be a structure that stabilizes the shoulder and put a ball back into the socket, just like the cuff is. When the cuff tears, the biceps is the only structure plus the coracoacromial arch that holds the ball back in the socket. So is it a structure that stabilizes the shoulder when the cuff is there or not there? And most people think that it is a vestigial structure that God has given to us to cause pain. Okay, so that is what we need to answer the question. So what is the biceps disease? So if you look at the first picture, every person who has done a shoulder arthroscopy, you will see a picture like that. That is not pathological. This is just a hyperemia or blood vessels being prominent because of you're moving your shoulder and the biceps going through the tunnel in and out. Normal, okay? So this clearly has delamination, so that is not normal. And certainly in a 75-year-old, if you shoulder scope them, this is what a biceps tendon would look like, okay? Obviously, this is called a lipstick lesion or a kissing lesion where the biceps is rubbing against and moving in and out. So that's pathological. Tears totally is pathological. And then detachment is obviously not normal, okay? Then if you look at an ultrasound, more on an ultrasound than anything else, you will see that the groove is empty. That means the biceps is subluxating in and out, okay? And you can see that very clearly that this is also not normal. Then below in 2010 describes what is called an R-class biceps, where you can do an MRI and will show you a big proximal swelling and a narrow biceps in the groove, okay? And these are the patients that you abduct them and ask them to abduct their shoulders. They can't do it at a certain level, they get painful, okay? Do you remember when we saw these cartoons, Tom and Jerry's, if you stood on the pipe proximally actually ballooned out of water. So this is a similar phenomenon where the transverse ligament in the groove is causing compression in the biceps. It's too tight, and therefore the biceps is becoming thick. So it becomes thick, it can't pass through the groove. It's like that triggering of the finger that you have, and this is what happens here. Okay, if you do an arthrogram, you can see that clearly this is what it looks like on the picture. And basically the transverse ligament is a problem, and if you open them, you can see big, huge normal biceps and very narrowed out biceps, or swollen biceps and normal biceps. I don't know which one is what, but I think it is narrow biceps and swollen out proximally, okay? Certainly there are problems at the attachment of the biceps, which is where there's a slap lesion, or there is detachment of the posterior labrum and the biceps come with it, or you have a tearing of the biceps, and then certainly the last picture shows that it is actually completely not in the groove where it should be, okay? So how do we identify them? You do certain tests. So there's tenderness in the groove, there's restricted forward elevation. There are some proactive tests, the speed and the ergus, and I'll go through that for a minute. And unfortunately, all these tests are very poorly specific, okay? And these biceps tendon problems also do occur with people who have rotator cuff tears and who have impingements. Okay, so if you look at this particular picture, this is looking at the sensitivity, specificity, and a positive predictive value and negative predictive value, and none of the tests are telling you exactly what you want to know from them. So they are great to help you if your diagnosis go with you, but they don't sort of take you out of trouble if you are not right. Okay, so I have an ultrasound and I do them in the office or clinic, and I can identify the inflamed bicep. I can also see if they're not in the groove, and I can also see if I can inject them locally to as a diagnostic test. So instead of doing Jurgensen and depending on Jurgensen and the speech test, I also look at the work. Okay, the MRI scan, like I said, is only helpful if you have a subluxation. So what will make me think of doing something is if the exam findings are each locally tender, I have a sublux biceps, or I can see the tearing of the tendon on the MRI scan, or I can see inflammation, or there is a biceps problem, i.e. the slap is there. Okay, this is a very American term, but you guys need to understand as an arthroscopist what we call is game time decision. I plan what I want to do it at the time. I do consult them before, but I make my decision when I'm going to do it at the time of the arthroscopy. Okay. The other thing is that if I'm doing an arthroplasty and a fracture reverse, I will actually do a bicep tenodesis at the same time, because the humeral head will go up and touch it and it will cause pain, and therefore the pain suddenly disappears in a few months' time when the biceps tears. So I'd like to do it controlled rather than the patient do it for me. Okay. So what choices do we have? Okay, the choices we have is you can do a tenotomy, you can do an arthroscopic procedures, you can do it low in the groove, high in the groove or below it, or you can do an open procedure. So this is the picture that I was traveling with my family to Wales for one of those holidays, and apparently there are various ways of getting to where you want to go, and good luck to meet that. So that's how the current method of managing bicep tendon is. You know, you make your own decision, you stick with it. Whatever you're going to do, it will work if you do a tenodesis. Okay, so we know biomechanically if you use a screw, tenodesis works really well. Tenodesis, which is an open procedure, although now some people are doing arthroscopically, it's an amazing phenomenon and it works all the time. Okay, so I will talk to my patients, and in the older sedentary patients, if they have a bicep tendon problem, I will do a tenotomy. Okay. Those are people who are not concerned about cosmesis, but you must remember if the patient tears his tendon, they may or may not end up with a Popeye sign, and they may not have dragging sensation and pain. But if you do a tenotomy, they will definitely end up with a bicep Popeye tendon sign. They will all have pain and they have dragging sensation. So you just need to be careful. But if the older patient and they don't have high demand, you can do a tenotomy. And I always tell my patient, you know, I am going to cut the bad part of your biceps and let it sag and leave the good part alone. If they don't freak out, I will do a tenotomy for them. You know, the benefits is it's quick and easy, and basically you go into the shoulder, you find the bicep, and you either cut it or burn it, and it will slide down. Because it's got another attachment, you still have function. Okay? The younger thinner patients who have concerns of their biceps Popeye sign, who's a manual labor, or he says to me, "What do you mean you would cut my tendon?" I will go and do a tenodesis with those patients. Okay? And I will tell you how I do it, but basically you can do it up here, you can do it up here, or you can do it up here. Always, as long as your tension is right, it will function. And I think we're doing this for cosmesis rather than anything else. There was a paper about bicep tenodesis without releasing transverse humeral ligament. Apparently it says that if you are doing a tenodesis, don't release the ligament, you will have to go back because 20% of them have got problems. Okay, so if you release them, very few had to have redo surgeries, but if you don't release them, about 20%, which is a quarter of them, ended up with problems long term. Okay, so where do we do the tenodesis? We've been talking about this. I started doing the open subpectoral. It was easy, it was good, and we had the button on the shelf, so we just did that. Okay. Then when I started doing arthroscopic work, I started freezing them or doing them at the top. It was easy approach to them, but now I do them in the groove, and I do cut the transverse ligaments from the evidence that's been around. Okay. So I have my patient on beach chair. These are my portals, normal posterior, normal lateral, and normal anterior portal. This is my magic portal. This is the portal for arthroscopic bicep tenodesis. It is anterior line drawn from the anterior crumb and 5 centimeters below. and I will show you how it works. So the first thing I do is I will go in, put a suture across the tendon so it doesn't run away from me, and I will detach it from where it is attached to the top of the glenoid. So once I've done that, okay, you have to detach it completely. Good. So now once I've done that, I will still remain in the same portal but go into the bursa, and I will see where my biceps tendon is. And because I put a suture on it, I will move it and I can see it moving in there. So I know this is okay. So the next stage would be to grab it. I'm still using posterior vision in the subacromial space, and my working portal is laterally. So I will put my grabber, I will find the tendon and grab it, okay, to bring it out to the center. Next thing is I will now use my direct portal, which is the 5 centimeters below the anterior acromion. This is my groove of the humerus. The biceps has been retracted with the tendon holder that we had, and we are taking out the transverse ligament and cleaning up the groove. Okay, but my working portal now is the anterior portal, or the 5 centimeters below, and my viewing portal is now the lateral portal. Okay, I will then make a hole from this portal, and then I will hopefully grab the tendon with my this anchor is the swivel lock, but it has got a loop to specifically made for the biceps tendon. Okay, I'll push it in and I'll screw it at the same time. It's just to make sure, because this will swivel, to make sure that it's not catching on anything else. Okay, so now this is my final screw going in. You can see the loop, that suture that I put in there. You can see how much distance it travels. Once I tighten it, you will have the squeaking, but you can see the tendon moves with the screw. You need to have enough laxity at the top to allow it to do that. Okay, and finally we cut the tendon at the site where you can see it just below the surface, so we can take the excess out. And this is what the post-op X-ray looks like. So I am in the groove just below it. It is nearly a subpectoral arthroscopic one. And the summary here is I do them all arthroscopic. I do tenotomy for the old. I do tenodesis for the young, and I do a high tenodesis just below the groove. I did a lot of open subpectoral ones. So you need to understand the fact that the bicep is not a vestigial structure. It is a source of pain. If you ignore it, your patients are not happy. So you may have to do something to get them better. Question time. Quick and swift, yeah? No, question time, I said. Question, Tariq, you want a question? No?
What's your main indication?
So I clinically assess them. I have these patients who have got pain in the shoulder, but I can't fit them into anything, right? So I know their cuff's not torn, and I know their labrum is okay. And I know they're not impingement because I've done an injection in the subacromial space and didn't get better. So then I now examine them locally directly by looking at tenderness in the groove, okay? So I will know that the tenderness is in the groove. I have also come to a few times now in the last 3 months, we have them on the shelf, but we didn't have all these on the shelf. I used to scope them. I used to find the biceps all gone abnormal. And I didn't know what to do with them, but I used to bring them back again and then do bicep tenodesis. But now I clinically test their local tenderness. And if the tenderness is where the groove is, I will inject them. If the tenderness disappears and the function is better, I will plan them to do a proximal bicep tenodesis. Sorry?
Anterior supraspinatus tear. So would you also do them at the time when you've got a small anterior supraspinatus tear and you've got the upper part of the subscap starting to go as well? So the nerve.
That's a different ball game altogether then.
Yeah.
The subscap tear does not happen on its own. It has to have something happening in the supraspinatus.
No.
So for me to repair a subscap, which is becoming a lot more easier, I will do a bicep tenodesis first before I do the subscap repair.
Yeah,
okay. If I am doing a superior capsular reconstruction for the young person who has got a deficient cuff, I will do a bicep tenodesis at the same time. Okay. So these are different kettle of fish. They're not what I just explained. You know, I can explain to you what the biceps tendon pain would look like here.
Sure. These are the isolated ones.
Yes.
Shah?
Come on, guys. I've talked about a very controversial subject and nobody has questions.
Mr. Shah, can I ask a question?
Of course you can. I'm waiting for somebody to ask questions.
Yeah, thank you very much. Again, a very, very interesting talk as always. and great to listen to like that. The thing is that coming to the biomechanics, you mentioned that the bicep tendon is a stabilizer of the shoulder. Well, that is a very, very agreeable sort of a term. Now, the problem actually starts when actually you are having slap lesions. Like if you're having a slap 3 in a younger individual, well, the other side of the data is saying if you repair your slap 3, they do not do well. Well, I read some studies that they said that approximately 40% the success rate is less than 40% in some part of the studies, and if it is done in younger individuals in a slap 3 sort of a tier. Now the question is that whether if you in a slap 3, if you don't go for a repair in a slap 3 and you go for a bicep tenodesis, you actually take out one of the stabilizers of the shoulder in younger individuals. Well, in the part of the world that we live in Pakistan, we are actually cricket lovers, and we actually people are very much in bowling sort of an activity and in overhead towards. When the shoulder is actually lacking the one of the very important secondary stabilizers, do you think that is an option to actually go for that, or should go for a slap 3 repair in this situation?
So there is evidence. I have a talk in Lahore on evidence on biceps tendon repairs. Okay, but we'll have a chat then. But the thing is, you must understand that these meditation. If you have a patient, a sports person who has got a slap tear, that's a different problem. So we in this part of the world describe them in two types of management. One is in-season management. One is out-of-season management. So in-season management is the patient is still playing, he is making loads of money, and he wants to back to doing sports straight away. In these patients, I have a row of steroid injection. I will give them a steroid injection. I will do an arthroscopic debridement, one of the two, and let them go back to their sport. But the plan is that once they finish their season, they will come back to me when they're off season. I will sort something out for them. So the evidence is that if you repair slaps, sports people, they have a higher chance or higher rate of failure. 80% of them who still have pain and they don't go back. If you do a bicep tenodesis in the slap 3, as you said, and they go back to sports. I agree that they don't have a superior stabilizing effect, but that's the chat you have with them. You can tell the patient you have the next 3 to 5 years where you will have where you play a sport, make money. Your long-term outcome is dubious. I have no evidence to suggest what's going to happen, but I know that your uptake stabilizes out, and you may have long-term problems. There is a paper, I will forward it to you, Sufyan. There is a paper that says that if you have a type 3 slap and you repair them, the arthritis, the top of the glenoid continues, they end up with subscap tear long-term. Okay, so you cannot do repairs and think that that's what it is, and you've done it because they fail. And that's because you don't know enough of these type 3 repairs, whether the biceps is a stabilizer, whether the repair is going to work, whether the repair we've done is good enough, all that kind of stuff, technicalities of the surgeon, the type of the lesion it is, and the sporting activities. So you have a choice. If you're a patient, I can make you for the next 5 years, and you will be happy, but after 5 years, you will have made your money, and I can't do anything for you, and I may have to do something in the future, which will stop you from playing sports. Or I can do something for you now, which will take your pain away from you. It will prevent you having problems in the future, but you may not be able to go back to sports. But that's the decision you have to make with your patient. Okay, so not an easy answer, a different ball game than what I presented today, but that's what I would do if somebody had a type 3 slap tear, which is you give them the option. I can do something for you now, or you can leave it alone and just get your pain better, but you can't play sports. You can play sports now, but worry about it in 5 years, what's going to happen to you long term. Not an easy answer, not an easy answer, especially in Pakistan, if you haven't got a patient who has influence in the surgeon to begin with anyway.
Thank you very much, Mr. Shah.
Okay, so Sufyan, while I have your attention, your consultant colleague from across the road in Karachi, what's his name? A pediatric foot and ankle, the pediatric foot guy who does a lot of arthroplasties also in this hospital.
orthopedic, Mr. Mansoor Ali
No.
Khan or Professor Amin Chinoy?
Amin Chinoy, sir. Sir Amin Chinoy.
Professor Amin Chinoy. Yeah.
Yeah. I'm just going to